So welcome everybody to our pediatric webinar series. I'm Dr. Elaine Schulte. I'm the Vice Chair of Academic Affairs and Faculty Development, Professor of Pediatrics at the Children's Hospital. And it's my pleasure to introduce Dr. Deb Campbell, our speaker for this evening. Dr. Campbell received her MD from the State University of New York at Buffalo School of Medicine and Dentistry. She completed her pediatric residency and neonatal perinatal medicine fellowship at Albert Einstein College of Medicine, Montefiore Medical Center. Dr. Campbell is Chief of Neonatology at the Children's Hospital at Montefiore and Professor of Pediatrics and Associate Professor of Obstetrics and Gynecology and Women's Health at Einstein. She conducted the Low Birth Weight Infant Evaluation and Assessment Program, or LEAP, clinic from 1988 through December 2022. Dr. Campbell is an associate editor of the AAP's textbook of Pediatric Care and Pediatric Care Online and editor of Neonatology for Primary Care. She serves on the neonatal expert panel of the New York State Perinatal Quality Collaborative, the Bronx Safe Sleep Task Force, the Hospice and Palliative Care Association of New York Pediatric Advisory Group, the New York State Department of Health Maternity Care Clinical Advisory Group, the AAP section of Neonatal Perinatal Medicine High-Risk Infant Follow-Up Work Group, and the Bronx Maternal Health Consortium. And in her spare time, she's going to join us this evening and tell us more about the enhanced primary care of the NICU graduate. Thanks, Deb, and welcome everybody.
Thank you so much, and thanks everyone for the invitation to chat a little bit about NICU follow-up or the care of these children in your practice. So the objectives for the next hour are really to identify some of the continuing health and developmental care needs of high-risk infants after neonatal intensive care, discuss a little bit about the evolution of the neurodevelopmental and neurobehavioral outcomes we see, and later functioning over the life course, and then spend a little time talking about families and how we can help them. And my disclosures were as noted by Dr. Schulte. So just who are the babies who need neonatal intensive care? As everybody I think is quite familiar. Certainly preterm infants are a mainstay of the work that we do, but also babies with congenital malformation and chromosomal anomalies. And for today's discussion, I'm going to focus more on infants with critical congenital heart disease. And then in terms of infants who are full term and late preterm, most often those infants will have a variety of transitional delays. Some will have acute illness. And again, for the focus of today, I'm just going to limit my comments to infants who survive hypoxic ischemic encephalopathy. This slide I always like to spend a moment on to just remind ourselves that although these infants have both acute as well as ongoing risks and concerns, their health trajectories are variable. In addition to risk factors, which might increase morbidities and adverse outcomes, there are certainly many resilience and protective factors that can really accomplish a lot. And just as if you look over here, when you think about it, health behaviors and healthcare account for 50%, but environment and physical environment and social, emotional, economic factors certainly play an equal role in outcomes. This was a nice study that was done from women and infants in Rhode Island that actually reminds us about the importance of our work with immigrant and other marginalized communities in terms of trying to assure that those parents feel equally as comfortable and competent to be able to care for their baby after the stay in the NICU. Women and Infants actually has a very robust NICU support program for parents in the NICU. They have a transition to home program as well. So they have really comprehensive supports for the families that they serve. And yet still, if you look at the graph on the right, we see that Although NICU support was assessed, at least in terms of the parents who commented, and those numbers were small, was deemed fairly comparable in terms of the immigrant parents who are in sort of the gold bar. When you look at those mothers' perceptions of their infant's well-being at the time of discharge, the mother's assessment of their own well-being, as well as their comfort with caring for their infant, they really felt less competent, less confident, and thought that their infants were not quite as healthy in comparison with American Native mothers. And when I say Native, that's how the terminology they use, but it's really reflecting those American mothers rather than the immigrant mothers. So I think it reminds us about the importance of really thinking about who it is we're caring for and really trying to assure, whether it's language barriers, cultural concerns, we need to really try to make sure that we have as good an understanding and support structure for our families. Among the common concerns that our parents express, as well as concerns from our pediatric colleagues, and I do have to thank my colleagues at CHAM, as well as several of the community pediatricians who care for our children. Parents often, their focus is on sort of the activities of daily living for a young infant, the importance of weight gain and feeding, the child's developmental milestones. Oftentimes, they're struggling with the cause for the preterm or sick birth, and also risk for recurrence, as well as, particularly for the preterm babies, the longer term effects of the early birth on the child. From the perspective of the clinicians, certainly concerns about, are there new recommendations that one needs to be aware of? The Academy is very good at putting out lots of policy updates. The adequacy of information on the discharge summary. Fortunately, those of us who have access to EPIC within our health system have fairly comprehensive information, voluminous information, but those infants who may be coming from other health systems, the information may not be as comprehensive. Certainly, the pediatricians are concerned about addressing the acute care concerns, developmental monitoring, and then what are the ongoing neurodevelopmental and behavioral risks that they need to be concerned about. As we think about transitions, and certainly childhood is filled with transitions, in the first 3 months, as I said, it really relates to the activities of daily living, feeding, weight gain, breathing, sleeping, and elimination. And then for those higher risk infants who may go home on medical technologies, whether home monitoring, oxygen, nasal cannula, whether they go home on tube feedings, the medications that they need. And then also the family's concern about the child's adaptation to the home and integration within the home setting. Also navigating the multiple healthcare appointments that they will have to support their child's health. Over the course of the remaining 6 months of the first year, oftentimes these children there are ongoing concerns about feeding, weight gain, catch-up growth, the child's overall general health, ongoing concerns about state regulation, and the ability of the infant to handle stimulation and social interaction. We now see the emergence of motor issues in terms of tone that can also impact daily functioning, whether it's sleep, feeding, development of positional plagiocephaly, as well as challenges related to the quality of, delays in receipt of, or even the ability to acquire age-appropriate milestones in these infants. As we move into the toddler and early childhood years, again, we now have a greater focus on early development, motor milestones, communication and language skills, and sensory issues. Catch-up growth continues also in terms of for those infants who may not have been automatically eligible for early intervention services at the time of NICU discharge, recognition of the need for speech and language therapies, as well as therapies for gross and or fine motor issues are the most common. Autism screening also comes into play, as well as preparation for the early childhood preschool years, when we start to see the emergence or heightening of social immaturity, attention issues, hyperactivity, which we see in anywhere from 10 to 20% of both preterm as well as other high-risk children, the early signs of learning differences, sensory problems, as well as, I mentioned, social immaturity. Moving through to adolescence and young adult functioning. In adolescence and young adulthood, we are more likely to have reports of those young people needing to repeat one or more grades, needing special educational supports, more likely to not finish high school, and less likely to matriculate to college. When you evaluate and explore the individual adolescent and young adult former preterm individual self-perception, though, they honestly don't perceive themselves as different from their peers, either behaviorally or emotionally. And this is data that's been replicated across North America, Europe, and in Australia. They do rate themselves lower in scholastic, athletic, romantic, and job competency measures. Among women, they report more difficulty with relationships and more mental health struggles. Parents of these young adults report more difficulty with behavior, social skills, attention, and scholastic competency. It is important to note, though, that you have to also remember we need to factor in socioeconomics as well as other potential confounders that could moderate some of these outcomes. Delving into a little bit of the specific outcomes when we think about survival, the EPIPAGE is an ongoing longitudinal study out of France where they track all of their preterm births. They've had 2 cohorts. The second cohort was born in 2011, and this was a recent publication reporting on the 5.5-year outcomes. And one can see over the course of development and the course of gestation, certainly by 32 to 34 weeks, the rates of disability-free survival are much higher than they are at the more extremes of immaturity, whether one is, and even in terms of the severity of the neurodevelopmental impairments, they are less. As you look at cerebral palsy, which is the purple line, rates go down with increasing maturity. The same thing in terms of the severity of neurodevelopmental disabilities and full-scale IQs under 70 decrease with increasing gestational age. Among the continuing health issues for preterm and low birth weight children, we have just about every organ system that can be affected, and we don't have time to go through and touch on each of these, but we'll focus on some. I wanted to start with a case, and we'll be going back and forth over the course of the talk back to these twins. They were born actually at different gestational ages. Elena came first at 23 weeks and 5 days. Her brother was able to gain advantage in terms of 11 days, and he was born at 25 and 2. You can see from the list of their medical complications in the NICU and the different interventions that they needed. Elena ended up being transferred to Blythedale at term corrected for intensive feeding therapy and ongoing rehab. When she left the NICU, she was on 27-calorie formula. She left Blythedale off of her respiratory meds and feeding on 24 calories. Her brother, who clearly had that advantage of those 11 days, did have a lot of the common problems that we see in the preterm infants. He was discharged just shy of 3 months, so at early term, and was feeding on post-discharge formula with 22 calories. In terms of, as we look at growth through adolescence and children born preterm, We can see the upper panel is males, lower panel is females. And these are looking at Z-scores for weight, height, and BMI. Is that over the course of time from infancy through early adulthood, there is catch-up growth that's ongoing at around 14 years. It tends to level off, so that both for males and females, for both weight and height, males and females preterm who were born preterm tend to be lighter and shorter than their term-born peers. However, what we do see by this same point in time is that BMIs end up being comparable. So this clearly suggests higher risk potential for these children. Monitoring growth in the early months and years. We use a combination, as I think everybody is probably quite familiar, of the Fenton curves, 2013 Fenton curves, which were harmonized with the WHO curves. And we use the Fenton curves through 2.5 months corrected age, and then switch over for those infants who were under 36 weeks when they were born to the WHO curves. And we continue to correct for the degree of prematurity until 24 to 36 months corrected age. And what determines whether you use 24 or 36, I think, is really the degree of immaturity as well as the medical complexity of the child, because we know that those kids with greater medical complexity will oftentimes struggle more with growth and weight gain. Our growth goals and the need for increased caloric intake do vary in terms of our recommendations based on whether the child is less than or greater than the 10th percentile for corrected age. And I just want to quickly point out this graphic here, as to me, this is an important reminder. A baby can be born at the 50th percentile, but they have a lot of different ways of getting there over that course of the gestational period. So it's important because this really gives us some additional influence or information about what's that child's actual growth potential over time. Who are the babies who need fortification post-discharge? Certainly those groups who weigh less than 2 kilos at the time of discharge, whose weight and linear growth is less than the 10th percentile for corrected age. Infants with increased metabolic requirements, those babies with BPD, congenital heart disease needing early intervention, babies with metabolic bone disease. In general, we say that the preterm infants need around 110 to 120 kcals per kilo per day, but they may need up to 130 to 150 based on, again, their growth parameters and what their metabolic requirements dictate. In terms of growth goals, optimally, in terms of optimizing outcomes, and data has shown that those babies that grow above the 10th percentile will have better neurocognitive function, optimally between the 25th and 50th percentile. But we do need to keep in mind that for a baby who may have been significantly growth restricted at the time of birth, or may have had significant challenges with growth during the neonatal intensive care period, may not easily achieve that 20th to 50th percentile goal. Certainly, again, optimally, now we recognize and value the importance of breast milk and breastfeeding for even our tiniest babies, and do encourage that, although there will be some infants who may need a post-discharge formula to supplement. And then certainly there are families who choose to formula feed. In terms of vitamins, everybody, I think, is fairly familiar with this guidance in terms of the use of multivitamins and the duration, as well as for vitamin D supplementation and iron supplementation. Babies in general who are on, I know they all go home with a prescription for vitamins and iron, but those babies who are just receiving a transitional formula and are feeding well typically don't require vitamin supplementation. Feeding issues are certainly the biggest concern and the greatest struggle for our families when these babies first go home, as I'm sure many of you have experienced as you're doing your initial visits with the infant over those first months. These infants may have a degree in addition to their issues with chronic lung disease, but certainly reflux, apnea less so, but certainly some of them may have feeding associated impact on their ability to control their respiratory function. Inappropriate feeding regimens can sometimes arise, either in terms of families trying to figure out how to get the babies to feed, or listening to guidance from other people in their sphere of influence. Certainly poor and slowing growth velocity, increased energy expenditures, abnormal tone, as well as issues related to chronic lung disease can contribute to poor growth and poor feeding. We have certainly the things that we think about in terms of feeding efficiency and feeding endurance related to oromotor coordination, difficulty coordinating suck-swallow breathing, feeding aversion that can develop, as well as structural anomalies in terms of infants who've developed palatal grooves from months and months of intubation and having orogastric tubes in place. These oftentimes not only contribute to early feeding difficulties, but ongoing feeding difficulties as the infants contribute to complementary feeding. Feeding should take in general less than 25 to 30 minutes to complete. There will be a small percentage of infants who may go home with supplemental tube feedings. If the child requires this for more than 2 to 3 months, or the child exhibits failure to thrive with growth deceleration, it's important to think about a gastrostomy. That's certainly done in consultation with GI, although certainly many of our families tend to try to resist this for as long as possible. And there are some infants who even at 18 months, 2 years, may still be on subs tube feeding. Infants who do have dysfunctional feeding are more likely to have ongoing difficulties as solids are introduced. And this can continue even through 12 months as they're transitioning to table foods. Eating problems can persist into later childhood as well, with increased difficulties related to oromotor sensitivities, just overall hypersensitivity and behavioral problems. In terms of the timing of introduction of solids, we typically say around 6 months corrected age, in conjunction with readiness skills in terms of postural control, loss of the early thrusting that you see. There's some interesting work out of the UK that documented that preterm infants were actually more likely to receive solids, both at 6 weeks and 12 weeks post-term in comparison with full-term infants. And this was seen more commonly among families that were formula feeding. There's a lot of controversial information and lack of clarity about the increased risk for eczema or atopy in preterm infants, although there was one study that did suggest that introducing more than 4 different foods before 17 weeks corrected age did increase the risk. Going back to our twins, we have Elena and who had BPD with some mild pulmonary hypertension, had wheezing, and had 2 hospitalizations for bronchiolitis. Her brother also had BPD, less severe, without any pulmonary hypertension. He had 3 hospitalizations, one that was initially triggered by bronchiolitis that then moved into, once he recovered from that, a need for laser therapy because he had an exacerbation of his ROP. And then both babies were hospitalized again at 16 months for a second bout of bronchiolitis. And it's important to remember that it's not just RSV. We see a lot of metapneumovirus, a lot of rhinovirus, and other viruses that cause respiratory illness in our babies. So 50% of babies with chronic lung disease do exhibit wheezing or reactive airway disease. By 8 to 14 years, though, Most of the children will show clinical improvement, and there are no differences in asthma rates in comparison with normal birth weight children. Overall lung function, when you do pulmonary function studies, is also essentially normal. So there's no difference in lung volume or air trapping, although there may be some reductions in airflow variables. And there's no difference in terms of whether the extremely preterm infant did or did not have BPD. We do know that as adolescents, extremely low birth weight teens do have lower aerobic capacity, strength, endurance, flexibility, and activity levels. And there are increasing reports of COPD in adulthood. And adults have been shown to have abnormal ventilatory responses to hypoxia, as well as hyperoxia that are deemed to be thought to be due to disrupted chemoreceptor development. Back to our twins again. So we know about their chronic lung disease. Both babies, though, also over the course of both their time in the NICU and after discharge, had issues with blood pressure. The girl had acute kidney injury during her stay and intermittent hypertension. She also had nephrocalcinosis that resolved by 9 months of age. And during her follow-up care, both with cardiology and in high-risk follow-up, she had elevations in blood pressure, and at 16 months of age was diagnosed with stage 1 hypertension. Her brother did not have history of AKI, but did also have intermittent elevated BPs and continues to be followed by nephrology for both elevations in systolic and diastolic pressures. So this has now been reported in numerous studies that preterm and very low birth weight infants have modestly higher systolic BPs later in life, and that this can begin as early as mid-childhood. And we see both differences in systolic as well as diastolic blood pressures, both in the early years as well as over time. There was some interesting data that was actually presented at PAS last month that shows that there's actually remodeling of the heart in many individuals who were preterm who now are adults. And that may be contributing to some of what we're seeing in terms of the increased cardiovascular risks. The AAP, in terms of its 2017 guidelines, did recommend blood pressure monitoring at each healthcare visit for preterm infants less than 32 weeks, those who were SGA or low birth weight, those who had histories of AKI or hypertension in the NICU, and certainly those infants who had umbilical arterial lines, and that to refer to nephrology if there were consecutive blood pressure elevations, consecutive visits with elevated BPs. Going over very briefly, there's an increased risk, therefore, for metabolic syndrome. If you remember, I pointed out in terms of the higher BMIs that we see in these children. So there's higher rates of insulin resistance, dysglycemias, as well as abnormal lipid profiles, abnormal fat deposition, higher risk, therefore, for type 2 diabetes, and an increased risk for chronic kidney disease later related to impaired nephrogenesis, exposure to nephrotoxic medicines, as well as the episodes of AKI. Nephrocalcinosis is interesting. Certainly it's multifactorial in origin. There are many of our medical treatments can potentiate or contribute to this. For most children, it will resolve by as late as age 7, and by 15 months, 2/3 of the children, the nephrocalcinosis will have resolved. Just very briefly, in terms of ophthalmologic concerns, beyond our risks and concerns about retinopathy of prematurity, once it regresses and resolves, these children, even if they did not need intervention for their ROP, are at risk for later retinal detachment in later childhood and adolescence. So it's been reported as early as 8 to 9 years of age. So that's one of the reasons why ongoing annual eye exams are so important for this group of children. There are also concerns regarding high myopia, cataracts, and glaucoma. We see in preemies in particular, but also in infants with complex cardiac disease and in some survivors of HIE, concerns in terms of visual function, visual acuity, increased risk for strabismus, as well as secondary functional amblyopia. In terms of hearing surveillance through a minimum of age 3 is very important in these children as part of their ongoing healthcare, as we see much higher rates of auditory neuropathy, auditory dyssynchrony in high-risk infants, particularly in those infants that are born preterm. And it's a function of damage to the inner hair cells. And the groups most at risk are not only infants born low birth weight, but babies who've been asphyxiated, babies who've needed ECMO, babies who've received ototoxic medications, particular if their families have the GJB2 connexin 26 mutations. And then certainly concerns in terms of infectious risks that increase the risk for hearing loss. In terms of oral health, I just wanted to point out that we actually do see, especially with the very tiny creams and those who've had very complicated courses, needed diuretics and had significant nutritional issues, enamel hypoplasia. And you see it here represented by this yellowing of the teeth, thinning of the enamel. And this is very common. We also see later tooth eruption in a number of the preemies. It seems to be a little bit more common in the girls and the boys, as well as I mentioned before, the concerns around palatal grooves and high arched palates, which can affect both speech and bite. In terms of plagiocephaly, it is common, certainly among our preterm people, but also in any of the babies who've been sick. So again, whether it's the baby with HIE, the cardiac infant, or a baby who had sepsis meningitis and had a very prolonged or complex course, positional plagiocephaly is very common. And beyond, sort of positioning, the neck exercises, tummy time, there are, a percentage of children will go on to develop some torticollis, which can impact development. And some children will need orthotic bands or helmets. The optimal timing in terms of current recommendations from the pediatric neurology societies is referral for evaluation between 4 and 8 months. The neurosurgeons tend to like the children referred as early as possible, so 3 to 5 months corrected age, so that they can at least evaluate and develop a plan, not necessarily to start helmet use at that point. We always have the discussion about those preterm infants who at 3 to 5 months really may not have sufficient neck and trunk tone and strength to think about, how they would manage having a helmet on. But still referring them early, the neurosurgeons will follow them all. And then at the appropriate time, start treatment with helmets. You get better outcomes if treatment is started before 8 to 9 months of age. Just quickly to mention, we use a lot of CPAP, lots of cannulas, and many of the babies will have notching, some septal damage, deviations, and may over time need some cosmetic interventions. Hemangiomas are also very common. The preemies tend to have multiple hemangiomas, I think related to the timing of development of these hemangiomas and the rapid angiogenesis we see starting between 31 to 33 weeks of development. Hernias are very common, with both inguinal as well as umbilical. And some interesting studies have been reporting on preterm birth and the timing of puberty. There does not appear to be a significant acceleration in the onset of puberty from one systematic review that was done. There have been reports of very preterm and very low birth weight adults having lower reproductive rates. Fewer get married, fewer have children, and some reports of associated shorter period from telarch to menarche. Although the age at menarche, although 2.5 months earlier than comparable term-born children, the overall age was still within the expected range. Shifting to some of the developmental needs and ongoing supports. Certainly we see the range of multiple service needs that we still see at around 2 years of age, 18 months to 2 years, with the children needing a variety of supports, developmental as well as ongoing supports, social work support for the families. And we also recognize that from studies that there are lots of missed opportunities in terms of high-risk infants who would benefit from services having not been referred for early intervention. And even among the late preterm population of children who probably are the larger cadre of children within your practices, for those late-term preterm infants who require neonatal intensive care unit admission, they actually have the same risk as their very preterm counterparts in terms of requiring early intervention services at 12 months corrected. Related to the range of developmental complications and concerns, these are related to what we see in terms of reduced brain volume, differential effects on developing gray matter, as well as cortical structures, particularly in the frontal, parietal, and hippocampal areas, as well as abnormal brain connectivity. So in terms of the brain microstructure, as well as the brain connectivity, so crosstalk between hemispheres, that will impact all the developmental domains. In general, intellectual consequences of prematurity, as I think everybody's familiar with, increase with the degree of low birth weight as well as the degree of prematurity, so that we see much higher rates for infants who are less than 32 weeks or 1,500 grams. But even among infants who are moderate to late preterm, the risk of intellectual disability is higher than for their term counterparts. And this was from a recent study that looked at school age outcomes by gestational age in New York City, that showed that for preterm infants, in comparison with their full-term counterparts, there were higher rates of special education need, as would be expected. But even for late preterm infants in comparison with full-term infants, they had higher rates of need for special educational supports. In terms of the overall academic consequences, it really does span all of the areas of performance and academic achievement, fine motor, language, visual, perceptual, complex language, memory, executive functioning, and this can contribute to teens and adults becoming more marginalized. We do see, when you look at the right-hand side, that the greatest number of supports are needed through 3rd grade. And after that point in time, after about, I guess, 6th, 7th grade, there are fewer supports needed. And this correlates with what we see in terms of cognitive scores over time. When you account for maternal education, brain injury, and gestational age, there appears, although we say in general that there's a cost of 10 to 15 IQ points, by being born preterm in particular, we see something similar in those infants with complex congenital heart disease as well. There does appear to be some catch-up in terms of IQ points, in terms of cognitive testing between 6 and 19 years of age. So that what we essentially see, the upper blue and green reflect term infants, the lower red hashed and straight lines reflect the extremely preterm population. So those infants less than 28 weeks, that over time there is some catch up, but we do see some improvement in cognitive scores. Less so, I think, as it relates to maternal education, and we know that that's a big factor in terms of resiliency and compensating for some of the differences that we see. In terms of infants with brain injury, there's also improvement over time. And then there's certainly the greatest narrowing when we just, everything is controlled for and we're just looking at extremely low birth weight by gestational age. Again, seeing the same thing. This was a study that looked at, compared individuals at 18 who were being conscripted into the army in Europe, their gestational age in comparison with their term-born male siblings. So again, we see the difference, and this minus 0.3 Z-score difference really accounts for its 4.5 IQ points difference. But this really moderates and almost disappears by the time the children, these young adults, reached 33, 34 weeks of development. Just briefly to mention about CP screening, we now have guidelines that really advocate for the importance of early assessment for the risk of cerebral palsy to assure that we can get these children into monitoring and appropriate therapies. There's guidance around early risk assessment in terms of infants under 5 months corrected age that include a combination of MR imaging, general movement assessment, as well as the Hammersmith neurologic examination as being most predictive for risk for CP. After 5 months of age, MR imaging and the Hein are most predictive. And it's one of the things that we've certainly integrated into the NICU as well as our follow-up assessments. Wanted to touch base briefly in terms of sensory motor integration. And this really is a function of sort of brain immaturity as well as all of the aberrant sensory inputs that happen to any infant, whether term or preterm, needing to be in a NICU. Much like they describe in the adult literature about ICU psychosis, we think of all the lights, the noise, the aberrant touch, the painful stim, the oral, inappropriate or excessive oral stimulation. These infants experience that can contribute to a variety of ongoing developmental and sensory issues. Some infants will be sensory seeking, others will have lots of sensory avoidance. And oftentimes these children will be tentative around other children, slow to engage, and really unsure of themselves. In terms of behavioral issues, again, focusing on the early adaptation in terms of state regulation, their ability to handle their environment. And this manifests and progresses over time. We see ADHD, aggressive behaviors, withdrawal, limited social skills. The risk for autism spectrum disorders is higher. And when you look at later childhood, early adolescence, there are higher rates of inattention, anxiety. And we do see, though, that IQ is a moderator between birth weight and anxiety. So the kids who are higher functioning seem to do a little bit better. There has been a preterm infant behavioral phenotype that's been well documented that again focuses on an inattentive subtype of attention deficit disorder with more internalizing behaviors, anxiety, worry, depression, social difficulties. Some children will exhibit externalizing behaviors, but it's less common. And even when one looks at late preterm infants, and I think, again, this is important because we have so many of them in our practice, that any psychiatric disorder, anxiety disorder, even risk for cerebral palsy in late preterm infants in comparison to full-term infants is 2 to 3-fold higher. Just wanted to make a quick mention about autism screening. We all are very familiar with using the MCHAT. The MCHAT is not as sensitive when you're dealing with medically compromised children, and you're much more likely to have a positive MCHAT screen at 18 to 22 months than if you do the screen closer to 30 months Although you'll still have a fairly high prevalence of, positive screens, and 8% of children born at less than 26 weeks at age 11 will be ultimately diagnosed with autism. There's a new play-based autism screening tool that I only recently became familiar with that differentiates between autism and other developmental delays, disorders. And it's interesting because it's something that, while it can certainly be done in practice, oftentimes now is being integrated into high-risk follow-up. Takes 20 minutes, and it really helps discriminate which children should be referred for more comprehensive evaluation. There are interesting differences in terms of the preterm autism phenotype that we see in children as well. So that although both preterm and term children exhibit similar scores with social affect deficits, restrictive repetitive behaviors, and their overall total scores, preemies tend to have worse nonverbal behaviors that regulate social interaction. They're more homogeneous in their reciprocal social interaction patterns. And interestingly, despite these challenges, they have more favorable peer interaction and social reciprocity. Shifting quickly, because I know I only have a few minutes left. Just wanted to touch base on infants with complex congenital heart disease. Another of our patients, Mila, and Mila's picture, which Grace shared with us in her story by her family. She was born with at 37 weeks, growth restricted, had a severe coarct, hypoplastic arch, myocardial dysfunction. Before she was able to have her first surgery, she had a stroke. After her surgery, at the time of discharge, she had reflux, nystagmus with roving eye movements, had an abnormal EEG, feeding difficulties, and had evidence of significant brain injury on her post-op MRI. Her ongoing issues have included hemiplegic CP, global delays, cortical visual impairment, strabismus. She's had early intervention services and committee for preschool education from early on. This was Mila 2 years ago when she started kindergarten. She had her preschool through Elizabeth Seton and then attended a private mainstream kindergarten, has an IEP, an individualized educational plan. Her vision's improving, still requires orthotics and uses a scooter because of her CP, but she knows her limits and advocates for herself. And the quotes on the right-hand side below her picture are from her mom, describing a really wonderful, social, engaging, curious child who really loves life. In terms of childhood outcomes for infants with complex congenital heart disease, we know that the vast majority survive to adulthood. There are common issues with growth challenges. We see neurologic abnormalities in their exams at 18 to 20, at 12 to 18 months, with fine and gross motor abnormalities predominating. 1 in 4 to 1 in 5 will have global developmental delays. And certainly as they grow, we see an increased prevalence of executive function difficulties with working memory and flexibility. Nearly 30% of these children will be on medications, and even into later childhood and early adolescence, a quarter of them are still on medications. 6% will have 2 or more hospitalizations after their corrective surgery, and nearly 4% will require additional cardiac surgical procedures over time. This is just to illustrate that the issues for children with congenital heart disease both start prenatally in terms of delayed brain maturation with evidence of white matter injury in anywhere from 30 to 50% of infants who are studied. That then is compounded by the effects of surgery and their post-op recovery that add then an additional layer of acquired white matter injury that affects both microstructural development of the brain and again, decreased connectivity. So very much like the picture we see with the preemies. And on the right-hand side of the slide is just to remind us of all of the different factors that contribute over the life course to outcomes and well-being. In terms of the specifics of what we see in terms of the increased risk for neurologic impairments, certainly the severity of the congenital heart disease will impact outcomes, but you can see that even for children with what's considered non-severe congenital heart disease, as in comparison with those with severe congenital heart disease, we still see 25 to 30% of them having cognitive impairment, as well as over 20% of them having difficulties with independent living over time. So it's something that we need to be mindful of and not just focus solely on those infants with the most severe cardiac abnormalities. And on the right-hand side, we can see from the National Survey of Children with Special Health Care Needs, the significant percentages and the range of difficulties that children with congenital heart disease have more difficulty with. Into adolescence and young adulthood, these impairments, just as were described for the preterm infant, are very similar in terms of the concerns, the impacts on functioning, and impacts on achievement, quality of life. There are decreased exercise tolerance and activities. Similar to the preterm population, infants, children, young adults with congenital heart disease rate their quality of life similar to their peers. And in studies that have been done looking at MR imaging, again, in young adults, we see that 1 in 5 has evidence of white matter injury and volume loss, and that's attributed to hypoxic ischemic injury that occurred early on. Just one quick slide about hypoxic ischemic encephalopathy. We see very similar to the other two groups of children in terms of risks for both disabilities, with anywhere from 20 to 35% of survivors having disabilities. Certainly the more severe the encephalopathy, the greater the impairment. But even for those infants who are most likely to benefit from our current therapeutic hypothermia therapies, we still will see significant motor deficits, impairments in memory, executive function, visual perceptual issues, increased hyperactivity, and delayed school readiness. And although therapeutic hypothermia is not currently the standard of care for infants with hypoxic ischemic encephalopathy, and their outcomes were reported to really be comparable to normal birth weight infants who didn't experience any of these difficulties. Studies are now emerging that show that there are some differences and that the cognitive outcomes for children with mild encephalopathy are actually comparable to children who have moderate encephalopathy who were not pooled. This is just some guidance from Canadian Pediatric Society about some areas of focus in the months after, in the early years after these infants are discharged from the NICU. So again, focusing in those first months in terms of growth, early milestone development, continuing on focusing on in preschool years in terms of preparation for school and school readiness, and then at 8 to 10 years, if there is evidence of school difficulties, really focusing on making sure that there are assessments done of language and auditory processing, as well as adaptive behavioral testing. In the last few minutes, just to take a little bit of time to talk about the experience of families in terms of parental mental health. We've talked a number of times mentioning the importance of social determinants of health. Equally important is screening for perinatal and postpartum mood and anxiety disorders. We do see that by 2 weeks of a NICU stay, There are heightened levels of anxiety, depression, and post-traumatic stress disorder evident in parents, with 40 to 50% of mothers and 30% of fathers exhibiting these signs. Parents, have to adjust to altered parenting roles. Again, the sort of the aberrant, noxious NICU environment, sometimes grappling with the appearance of their infants, whether it's a little tiny human, or seeing their baby with lots of tubes and wires, who may not be as responsive, or able to, handle or interact with their environment. They have a high level of perceived child vulnerability. Added to these stresses are the separation of the parents from the child. Again, the NICU environment that really sort of creates a barrier, because the people that are keeping the baby alive are really the medical team, the nurses, the respiratory therapists, the physicians. And this, again, can alter the parenting perception of their role, and certainly the infant's high-risk course. Just a word about medical post-traumatic stress disorder. It's exposure to a traumatic event in which a person experiences, witnesses, or is confronted with events that involve actual or threatened death or serious injury or threat to physical integrity. In terms of, sort of the stressors and the responses, our families, have to grapple with recurrent recollections about diagnosis, treatment. They can ruminate, and have future-oriented fears about, again, treatment, prognosis, relapsing death. Avoiding reminders of the event is something that is common in this situation, but you can't avoid it because your child is still in the NICU or still needs to come back to the hospital, to the emergency department for specialty follow-ups. And that can just re-trigger parents. Negative cognitions in terms of irrational feelings of guilt. Our parents, particularly our mothers, have tremendous guilt, and as much as we tell them it's not their fault, they carry that with them forever. Negative expectations about futures sometimes is a concern as well. Hypervigilance to medical cues, hypervigilance to somatic symptoms that can that they may feel will indicate recurrence of disease, hypochondriasis on the part of the parents as well. And going back to our twins, the mom was very stressed about both babies because of their varied health issues, fear of severe illness, because of their complicated NICU courses. She was seen they were getting their care at one of the Monty sites, and they were linked up with the Healthy Steps program. We saw her when the babies were 4 months corrected. At that point, the mom seemed to be coping well, and there weren't any obvious signs of hypervigilance. And this was actually after the first hospitalization that the kids had. We saw her 4 months later. And by that point, the mom was really exhausted. She was more stressed and more anxious. She was hypervigilant, unwilling to leave her children with anyone, including her husband or his mother, who had come, moved in with the family to help take care of the children. The day she came, she was in severe pain because she had fallen on the wet floor while cleaning. She refused to take pain meds because she wanted to be alert to monitor the babies. Why did she fall on the wet floor while cleaning? She was cleaning her home 3 times a day with bleach because she didn't want the kids to get infected. She was making all of her children's food from scratch. She had actually been referred by Healthy Steps for a homemaker, but it was denied. So just as an example of what we can see early on, and these issues can certainly persist, and they can have long-term ramifications for our families in terms of we will see difficulties with discipline and ability to limit set with our preemies as they grow, as the parents constantly are reflecting back to the early course and the baby's history with prematurity or sickness. And disciplining can sometimes be associated with flashbacks to the infant in the NICU. So this is one area that pediatricians can also be very helpful in terms of helping to guide and support the parents through discipline, through limit setting, and just recognizing the importance that these kids really do benefit from a structured environment. So, sort of supportive parenting can be very, very helpful to the kids and also to the families. The overprotection we've already talked about, and certainly the ongoing vulnerability. This is just to mention very briefly the importance of what we can do in terms of helping to scaffold not only the children, but our parents. By engaging the parents, getting them involved from the time the baby is born and admitted to the NICU through discharge and the transition to the primary care community, with the goal being to engage, educate, empower, and encourage our families so that they can achieve the competence and confidence that they need to really feel that they're being successful, effective parents in taking care of their preterm or a child who had medical complexity, as well as the other members of the family, particularly the siblings. And then also helping them navigate their fears of, will this happen again? Just to highlight, and this is my second to last slide, the importance of thinking about, do we have in place, and how can we set up those transitional support services to really help assure the health and well-being of the child and the family, whether bridging services from NICU to the community, other transition services. And then lastly, just from Mila's mom, she wanted to specifically offer some suggestions to pediatricians regarding how you can support the children as they move from preschool into kindergarten and elementary school, particularly as it relates to their ongoing therapy needs. That oftentimes the special ed committees will try to cut back on services, and the importance of recognizing that ongoing, even if the child is doing well, the importance of ongoing services in the primary years is really very important and beneficial to the child, and that the parents really do need the pediatricians to advocate for the kids as much as the parents are in terms of getting the school districts to address and support the children's needs. And lastly, in terms of linking them with different support programs to help the families sort of navigate these new transitions and experiences, and also so that they can they can share with other families as well as be the beneficiaries of resources that other families have amassed over time. That link at the bottom is actually a wonderful site out of the UK that's designed for educators focused on preterm infants, but I think has a lot of utility and applicability for all of us who care for these kids. Because I know that certainly in terms of some of the kids I see back in follow-up, parents will come to me, when the child is now first, second, third grade, and they've hit the wall. And the teachers don't know how to help the kids. They don't quite understand what to do, how best. And this site has wonderful guidance on all different aspects of learning, different strategies and tools, as well as gives background information for teachers so that they can understand what are some of the factors that have contributed to where the child is now. So with that, thanks everybody. And I don't know if we have any time left for questions, probably not, but if we do, I'm happy to stay and answer any questions.
Wow, thank you so much, Dr. Campbell. It's an amazing overview, and I hope our participants appreciate your phenomenal expertise. So we are out of time. It looks like maybe there's
before everyone leaves,
go ahead, Mike.
real quick, I just want to share the
oh
the
yeah,
CME
sorry, I
information.
forgot to mention about right. I forgot
It's
to mention.
So the next presentation we're going to be sending out is with Dr. Elizabeth Alderman and Dr. Jennifer Davila, and their topic is going to be menstrual bleeding in adolescent girls, too much or too often. This is going to take place July 12th at 6 p.m. Wednesday. A little information about Dr. Alderman. Her practice location is 3415 Bainbridge Avenue. Same with Dr. Jennifer Davila, 3415 Bainbridge Avenue.